Hi, my name is Amanda Spitkowski, and today I'm going to talk about healthcare policy analysis and look at the Senate Bill 630, which is Behavioral Health Services in North Carolina. So what is policy? According to the Centers for Disease Control and Prevention, policy is a law, regulation, procedure, administrative action, incentive, or voluntary practice of governments and other institutions. It's important to analyze policy because it provides a detailed analysis on what the policy means, who it is aimed at helping, and how it will work. Analyzing policy is important for everyone. It helps everybody to understand why a certain issue is important to those involved. It breaks down the issue and explains ways to fix or improve the issue. With policy analysis, we'll first look at the background and the variables. All three levels of the government play a role in policy and policy analysis. The local government focuses on implementing policy within the community, such as in hospitals and public housing. The state level focuses on implementing policy within the entire state. They focus on Medicaid, elderly services, accrediting hospitals, regulation of healthcare costs and insurers. They also look at the health departments, which focus on health monitoring, sanitation, and disease control. The federal level of government focuses on implementing policy within the U.S. on a larger scale. They focus on Medicare, Veteran Affairs, the Affordable Care Act, and to an extent play a role in Medicaid. All three contribute to creating and implementing healthcare policy. Focusing on a few more variables. Cost. Who will provide the funding? How will the funding continue? And will funding the policy benefit those providing the funding? Ethics. What is the long-term benefit to the policy? Are the resources adequate enough to meet the demands, or are those making the policy committed to the values and ideas of implementing the policy to help or for their own agenda? Will the policy do more harm than good? The stakeholders. Policymakers will push for policies that affect their agenda or that they are passionate about, especially around election time. Vulnerable populations. Who is this policy going to serve? How will it affect those if implemented, and how will it affect those if denied? And then resources. What resources are available to contribute to the policy? Okay, now we will look at the bill. The Senate Bill 630 is the bill to revise the involuntary commitment laws, or IVC laws, to improve behavioral health in North Carolina. It was passed as a bill on June 22, 2018 by Governor Roy Cooper. North Carolina is a state that has limited mental health care center resources for the increasing mental health population. Within the last year, over 100,000 residents in North Carolina have been taken to the hospital by law enforcement and placed on an IVC hold while awaiting treatment facility placement. North Carolina currently only has 7 state-funded mental health organizations. North Carolina residents, those with and without mental health illnesses, have lost trust in North Carolina's mental health system, as they have been continually let down by the system. Many of the mental health agencies have been shut down due to lack of funding when lawmakers consolidated and privatized mental health services and defunded inpatient treatment facilities. There are simply too many people with mental illnesses in North Carolina and not enough places to put them. Too many people with mental health illnesses are being involuntarily committed with no place to go other than the emergency departments. Once taken to the emergency department and placed on an IVC hold, these patients are spending days, weeks, or even months waiting for placement in a treatment facility. Senate Bill 630, the IVC law for North Carolina, was revived and passed quickly with little to no warning to those involved in the mental health field. Many individuals that serve on boards and committees in the mental health field were left out of the discussions regarding this bill. The sudden passing of this bill left little time for discussion and changes to the policy, which adds to the distress felt within the North Carolina's mental health field. This bill is aimed at revising North Carolina's laws to address the flood of people with mental health problems in the emergency departments. Now we're going to look at what the bill actually entails. The Senate Bill 630 focuses on improving the involuntary commitment laws within North Carolina. This bill has 45 sections. We're going to go over some of the most important sections that are covered in this bill. Section 1 goes over the definitions and the revision of the definitions that were in the previous bill. It highlights specific terms such as commitment examiner, danger to self or others, health screening, incompetent, an outpatient treatment physician or center. Section 3 talks about client exceptions. This section allows facilities to disclose time and location of admission or discharge to the client's next of kin when the professional determines that the disclosure is in the best interest of the client. Section 4 focuses on exceptions in court proceedings. This section says that it allows clients' legal counsel to have access to any medical and court records that the counsel deems relevant to the court proceedings. Section 7 focuses on powers and duties of area authority. This section focuses on developing and adopting community crisis service plans. Section 8 focuses on LME, Community Crisis Service Plans. LME stands for Local Management Entity. This requires local management entity to adopt a community crisis service plan that encompasses separate local area crisis service plans for all regions within that entity. Basically what this means is that each community is required to have a community crisis service plan up and running for mental health patients to access. Continuing on with Section 8, talks about the community crisis service plan must include facilities where patients can be taken for an exam, identify who can transport these patients, and identify training for law enforcement who provide custody for IVC patients. Section 9 talks about transfer of clients between 24-hour facilities or to an acute care hospital. This section states that if a patient is a minor, incompetent adult, or one with a healthcare power of attorney, the responsible person must be notified within 24 hours of transfer. And this includes transfers between two 24-hour facilities or from a 24-hour facility to an acute care hospital and/or back. Section 14 talks about voluntary admissions and states when patients make advanced instruction for treatment, physicians would be required to act within that instruction. This includes psychiatric advance directives. Psychiatric advance directives are instructions on the best way to handle the patient if they cannot communicate. Section 19 focuses on custody and transportation. This section states that there's limitations and conditions on force and restraint, and this does not apply to acute care or general hospitals. Section 20 focuses on fees under commitment orders. This section states that it requires a private physician, a private psychologist, commitment examiner, or private facility to accept patients as a client either before or after commitment, and treatment is at the expense of the client. That basically means that if a patient is involuntarily committed, that the patient is responsible for the fee. Section 24 is the first examination. This allows area facilities to determine who is qualified to perform medical screening for the first exam. Continuing on with Section 24, it goes on to state when outpatient commitment is recommended by someone other than the treatment physician or center, that examiner is required to contact the LME, the local management entity that serves the area, to inform them of this recommendation. Section 25 is the Secretary Authority. This allows health professionals whose scope of practice includes diagnosing and documenting psychiatric disorders to determine capacity to give informed consent to certify a nurse practitioner, physician's assistant, or a licensed professional counselor to conduct first exams. The bill states that this cannot be construed as a scope of practice expansion. In other words, this does not say that NPs, PAs, or the counselors can perform outside the scope of practice governed by the state. This also requires that the North Carolina DHHS to submit a list of all first commitment examiners to each judicial district. Section 27 focuses on outpatient commitment. Outpatient commitment is when a patient has been committed but is not required to have to stay at a 24-hour facility overnight. They are required to come on a daily basis to the facility for treatment. This section states that physicians are required to contact the local management entity that serves the county and where the client resides if they are being recommended for outpatient commitment. This is so that the local law enforcement and judicial systems will know that the patient has to show up for treatment. If they don't, then law enforcement can get involved. Section 33 focuses on special emergency procedures for violent individuals, and it states that when a client is violent and requires restraint, law enforcement may take the client into custody and take the client immediately before a magistrate or clerk, and that is to protect themselves and others. Section 34 focuses on duties of law enforcement and the commitment examiner. This section states that law enforcement shall take the client to a facility or other location identified by the local management entity and the Community Crisis Service Plan that has an available commitment examiner and is capable of performing a first exam along with a health screening. Section 36 focuses on commitment and second exam and treatment. This states that within 24 hours of arrival at a 24-hour facility, the client shall be examined by a qualified professional. Section 39 focuses on duties for follow-up on commitment order. This states that the facility or physician responsible for management and supervision of the client's commitment and treatment may prescribe appropriate treatment either on an outpatient basis or a 24-hour facility. If the client whose treatment is provided on an outpatient basis fails to comply with all or part of treatment after reasonable effort to solicit the respondent's compliance, the facility or physician may request the clerk or magistrate to order the client be taken into custody for the purpose of an examination. Section 42 focuses on releasing. This section states that the facility or physician shall discharge a committed client unconditionally at any time once it is determined that the client no longer meets the commitment criteria. Section 43 focuses on the local plan. This states that the local plan shall be submitted to the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services on or before October 1st of 2019. If the plan is modified, the updated plan shall be submitted at least 10 days prior to the effective date. The department shall provide the data collected by the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services concerning the number of clients receiving treatment under IVC and designated facilities on October 1st of each year, beginning in 2019, and at any time upon request. Now we're going to look at some of the ethical implications regarding the IPC law. One of those implications is forced treatment. Are those with mental health problems being forced to get treatment? Is the treatment effective? Who is paying for the cost of this treatment? How many times are these people being forced into treatment, or how many times are they attempting treatment and not ever completing recovery? Another ethical implication is the Psychiatric Advance Directive, which we talked about earlier. This is the client's treatment wishes if they cannot communicate them. It's like the Advance Directive and the Living Will, but for psych directives. But there have been challenges if the providers will uphold the wishes if they do not agree. Some modifications and recommendations for the IVC law. Funding and structuring of the mental health care system around more up-to-date and effective service provisions. How are we going to fund and structure the mental health care system to make it more effective? How are we going to allocate the funds in different areas of the state? If we wanted to open more inpatient mental health treatment facilities within the state, who are they going to be run by? Who's going to pay for them? How many patients will they treat? How many patients at a time will they hold? Should we increase more involuntary outpatient treatment options? Instead of having patients stay overnight at these 24-hour facilities, if they are able to do the outpatient treatment and come in every day, would that be a better system? Give patient treatment options. Instead of forcing them into treatment, offer them multiple ways of treatment and let them choose what would be best for them. Do not force treatment. And finally, continuing with recommendations, where will the funding come from for these increases? Will it come from increasing taxes? Can we pull money from other sources or other policies? How can we get the community involved and sponsors? Also, how to get stakeholders to be more invested in changing policy. Maybe add some community meetings to meet with those directly involved in the mental health care field. Create events to increase interest and support for mental health care. Get the media involved. Utilize TV, radio, and newspaper, Facebook, social media to keep the community informed of what's going on with the mental health care system. And sharing stories. Everyone knows somebody who deals with mental health. If it becomes important to the people that make the policies and have the money, then something will be done.